So a lot of patients do have borderline cholesterol levels. And so I'm going to talk a little bit about the lifestyle choices that we can do. And I think, honestly, most of us know what to do, but putting it into practice is the challenging part, right? And why I specifically talk about that LPA, the lipoprotein A, is that because a lot of patients will say, hey, I have high cholesterol. I've taken, I don't want to start medication. I want to do some lifestyle changes. So they'll go home, they'll clean out their pantry, they'll start choosing, foods which are a low glycemic index, no, don't increase risk of cholesterol, and try to make all those lifestyle changes. Like they may start exercising, they may start sleeping better. They come back, their cholesterol is still elevated. So what that means is that there could be a ethnic or genetic component to your high cholesterol that no matter what you do, it still will be elevated. And it's at that point that considering a statin or a cholesterol lowering agent can be very valuable. And again, I have women who say, I don't like medication. I've never taken medication. Why do I need to do this now? But as I mentioned, cardiovascular disease you don't necessarily know you have it until you start getting screened for it. So the earlier things that you can do for prevention, including considering a cholesterol lowering agent, would be very, very valuable. And I think sometimes we just have to get our heads around that idea, because sometimes there can be resistance in starting medication when you feel like you're doing everything right and you still have an elevated cholesterol. And that is because of non-modifiable risk factors, which I'm going to just draw upon now.
Okay.
So when it comes to cardiovascular risk factors, here are the things that we don't have control over. We don't have control over how old we are. That's going to happen regardless of what we do. Number two, our ethnicity. So if you are a woman of South Asian descent or Asian, you may have higher risk of developing cardiovascular disease. That is part of our genetic makeup, and we don't have control over that. So that is something that is, a non-modifiable risk factor for me. Family history. So if your family member, a first degree relative, a woman under the age of 55 has had a stroke or a heart attack, or under the age of 65 for a male, that is considered significant family history. So if you have family history of stroke or heart attack, that is a non-modifiable risk factor that you don't have control over, but that should be taken into account when you're thinking about your own heart health and your own heart risks. Personal medical history. So if you, for example, have, let's say, diabetes, right? You've now been diagnosed with diabetes. It even could be type 1 diabetes, which again is an autoimmune form of diabetes. That's something that you did. It just happened when you were a younger person. And now you are basically on insulin for the rest of your life, which can be very difficult to manage. That history is a non-modifiable risk factor because you can't do anything to reverse that. Socioeconomic status. We know that patients who have a more difficult time accessing good nutrition or good activity, like physical exercise, or being able to access just general health care, can make it more difficult for you to manage your heart health. So these are non-modifiable risk factors in compared to the things that we do have control over, which are called modifiable risk factors. If you can go to the next slide, please. So these are the things that we can control. Physical inactivity. Now, we know that exercise is such a crucial, important part of our health, but trying to find time to dedicate to exercise or things that we like to do can be very difficult. There is recommendations for about 30 minutes each day, 5 days a week, which is about 150 minutes of activity per week. And in particular for women, strength training has now become the new thing, because when you strength train, you are building your muscles and muscle mass. You are decreasing your risk of developing osteoporosis and frailty as you get older, and really maintains your metabolism and decreases risk of weight gain. So when it comes to activity, any form of exercise is valuable, but if women are really trying to focus on what should I be doing, strength training is very, very important part of our midlife wellness and health.
Yeah.
An unhealthy diet, again, we know what we should be doing, but really focusing on protein and fiber, minimizing things that come in packages, which are processed and are not from, the general fruits and vegetables aisle, can be very difficult and can also increase our risk of heart disease. We don't realize what is contained in our foods. And I could, again, spend so much time talking about this, but that's another big part of our health that we do have control over. Smoking also increases risk, not only for heart disease, it increases risk of renal cancer and lung cancer, and is something that no amount of smoking is ever good. So again, when patients have this as a long time habit, it's very hard to break. I fully understand. And so having your family doctor support you through smoking cessation can have a dramatic improvement in your quality of life as well as your heart health. Alcohol use, the 2023 guidelines have now recommended no more than 2 alcoholic drinks per week. For women, it used to be 9. So from
Yeah,
9 to 2 is a huge, huge change.
huge.
Um, and we don't realize the calories and the impact that alcohol can have on our health in so many different ways.
Yeah.
And so trying to manage your alcohol consumption is a significant important part of your modifiable risk factors. And finally, stress. All of us have life stress. Life is moving very quickly. It's hard to slow down and take time for nature walks and good sleep. And so, whatever we can do to manage our stress will also have a significant impact on our heart health as well.
Mhm.